Well, I think, first of all, Jay, Shah and team, thank you very much for inviting me. It was a wonderful evening yesterday, and now I'm fresh. We're going to discuss about rotational atherectomy, the cornerstone of treatment. The question is that you are going to deal with a calcified lesion. That information comes when you put your foot on the foot switch and do a fluoro. Because the only non-invasive method that can tell you about the calcium is a CT scan, and the CT scan is not routinely performed before you perform a regular angiography. So that you are going to deal with the calcified lesion, that impression, that information comes when you put your foot on the foot switch and do a fluoro. And on the basis of imaging, the calcium could be superficial calcium, eccentric calcium, severe protruding calcified nodule, and a deep calcified lesion. Of significance and importance to us is a superficial calcium. The calcium which is closer to intima, and that is the one which is going to create problem for us. And when you see a de novo calcified lesion, how do you assess this calcium is severe or not severe? Merely by angiography, then there are following methods. The mild calcium is one which has a specks of calcium and you find a little difficult to even see. Moderately severe calcification, when you see calcification when the heart is mobile. And the severe calcification is when you see the calcium even when the heart is steady and the calcium is on either side of the wall, what we call as the tram track calcium. That I think is severe. All right. When you assess the de novo calcified lesion, is the lesion functionally significant? No. Functionally significant, we heard just now from Dr. Ajay Swami that how do you assess the functionally significant lesion? Then I think we are entitled to continue medical therapy. Then go down and see, is the lesion complex like left main, triple vessel, syntax score more than 22, diabetes? Yes, high. Then I think there's a reasonable option is coronary bypass surgery. If not, and low, then PCI. The angiographic calcification, mild, moderate, and severe, we just discussed, but then I think sometimes you will require IVUS and OCT on the basis of IVUS and OCT, but that's not the subject of assessment of calcium today, so I would not dwell on to it too much. But I think that suffice it might say, the simplest way without the imaging available to you to judge whether the given calcium is to be treated by routine traditional management like with the balloon and cutting balloon, or it would require atherectomy. Now, that I think the simple method is, my principle is this, that when I take that, all right, I want to give a trial, take a lesion, pass the balloon, in about 12 to 14 atmosphere, you find it's dumbbelling and not yielding, then I think I have no hesitation to switch over to rotablation. In other words, now that we have a drug-eluting stent which has been able to produce the result in chronic stable angina, fairly equivalent to surgery, even in long-term basis, I think it is good that we all have to learn how to manage calcium and calcified lesions and conquer the calcium. Now, the birth selection. First, you try to judge what is the size of the vessel. And usually we prefer these days not debulking aggressively, but 50% debulking for the lesion modification, which we call as lesion modification, which I think is a 50% debulking. And therefore, see the size. And the largest possible burr you might need, that should be the size of your guide catheter. To give an example, 6 French catheter can accommodate 1.25 and 1.5 with difficulty, but 1.75 burr will require at least 7 French guiding catheter. So I think in case if you feel that you are likely to need 1.75 burr, right from the beginning you should take the catheter which is 7 French or 8 French. All right. What are the contraindications? When will you not do? You found there is a calcific lesion, and when will you not do? These are relative contraindications, mind you. In the expert's hand, this may not be contraindication. Avoid the patients with ejection fraction of 25 or less. Avoid. I'm not saying totally abandon. Avoid. The reason is this. that no matter what you do, there will be some amount of microvascular surging and some loss of myocardium, and that may be too much for a patient who has a 25% ejection fraction. Anyone who has a systolic blood pressure of 110, because rota is a spasm-provoking procedure. At the same time, it is associated with rota, there is sometimes fall in blood pressure, and this might precipitate a profound myocardial ischemia in the lesions other than which you are trying to address. If there are many more lesions in the other vessels, then I think it can create a hemodynamic crisis. Do not burn more than 2 vessels at a time, because the total amount of microvascular surge, anticipated microvascular surge, can be damaging one. Avoid lesions which are longer than 25 millimeter. Mind you, these are relative contraindication. I might be able to show you some cases which are more than 25. Lesions with the angulation in excess of 45, we have to do it very, very carefully. And I think undersizing the burr in those kinds of situations is very, very essential and even important. Vein graft, no, you should not do. If especially the old vein grafts which are thrombosed, I think it is a contraindication for sure. And acute coronary syndrome with a visible thrombus, clear-cut, large amount of thrombus. A mild thrombus is still not a contraindication. I think the tips and tricks now. First of all, rota does not require strong backup, not needed. But it does require coaxiality. If your guide catheter is not coaxial to the initial segment of the artery, for example, left main or right coronary, then I think you will not be able to achieve a good rotablation result. If the burr is more towards the inner curvature, that means the wire. If the wire is traveling towards the inner curvature, then I think the burring, in case if the perforation takes place, it would be either in the myocardium or in the septum, it's a left coronary artery, and it's unlikely to create a cardiac tamponade, which I think is a deadly complication. Now, I think not much attention has been given to wire bias. So I'll talk a word or two about wire bias. Wire bias is a thing which you can adjust. It's a stainless steel wire. So it's not a floppy wire. It's a very strong wire. And you can adjust the wire bias by either pulling the wire back, or you can adjust the guide catheter position, either rotate it or withdraw it or push it in. This, I think, people who are performing TAVI, transcatheter auricle the replacement, they know the importance of how to move the wire and bring it in the center of the aorta or to the outer curvature. So the wire bias is important. Moreover, if the wire is biased towards the lesion, then it is likely to burr the lesion. And sometimes when the artery is large and the burr is a little bit too small for the artery, then the wire bias can be profitably used to selectively burr the lesion. So either by withdrawing or rotating the guide you can achieve. And how to manage the distal tortuosity. This slide is not meant to show you distal tortuosity. Whenever there is a distal tortuosity, your wire should not be too much inside the vessel. Just 2 or 3 centimeter distal to your lesion is enough. Longer you go, like it will have a draw sheet or curtain kind of effect, because the artery could be curved and it could be soft, whereas the wire is strong. It's like a rod onto on the curtain, and the curtain takes the fold. And that kind of thing happens, you get pseudo lesions. The pseudo lesions are likely to burr the intima and media, and it can create even a perforation. 2, pseudo lesion also limits the flow in the distal segment, which is very essential. Important thing for you all to remember, that whilst you are doing rotablation, tell your partner, tell your assistant, keep on injecting small amount of fluid or a dye continuously to make a washout. If the washout takes place, you will minimize. Particle size that is made by rotablation, 70 to 80% of the particles are 7 microns or less, but some particles are bigger. Now, therefore, if you're with the correct burring technique, if the particles are small, they will be washed out into the reticuloendothelial system, because it will go to the capillaries and though eventually go to the spleen. But if the particles are large, then I think it is likely to cause microvascular sludging and little hemodynamic deterioration and sometimes little troublesome emergency, slow flow, no reflow, bradycardia. Those are the complications which I will deal in due course of time, but that is likely to happen, and that should not be allowed. For that, I think the perfect burring technique is essential. Two things is required: patience and appropriate knowledge. The burring speed, initial selection of the burring speed, not allow the rotation to drop by more than 5,000 revolutions. Do a wood packing movement. Don't try to push. If you push quickly, then I think it will make a large particles. And not only that, but there is a risk of a burr entrapment. So those things are very essential. And this you get either from the proctor or repeatedly doing the procedure, and then you acquire the expertise. Do not stop burring in the middle of the lesion. The burr may not retract. Occasionally, and there is a mechanism. If the burr speed drops by more than 15,000, there is a built-in stalling. It will stall, and then I think you will be landed, you will be in a big trouble because the burr may be entrapped, and then or it may be trapped, and I think it may be difficult. It may be. So do not escalate and de-escalate the speed while the burring is on. One, you want to change the speed, bring it stagnant position, bring it forward, proximal to the lesion, change the speed, and then push it. 1 or 2 polishing runs are enough. What should be the standard speed? Currently, it is believed that irrespective of the size, 1.25, 1.5, 1.75, 160,000 revolutions per minute is the standard speed. But I do not agree totally. There are situations where the lesions are hard, and if the burr is especially small, smaller the burr, higher the speed is often needed. And I think at that time, I think it is left to the operator as to how to change the speed and escalate the speed as and when needed. All right, so basically I might quickly summarize that the wire should be, the guide catheter should be coaxial, in the right coronary, preferably with the side holes. I prefer to have side holes in the right coronary guide catheter. Then the burring, bring the rota burr to the proximal segment, and I will show you in the due course of time. When you take the burr into the proximal segment, just proximal to the lesion, you start retracting it back. And you find that the burr is not moving, it is because of built-in torque. Moment you remove the complete torque, the burr will move. Then only after the burr, one moment the burr moves, you are very sure that you removed the complete torque or torsion inside the your burr or inside the drive shaft. Now, is when this happens, if you put your foot on the foot switch, if the burr lurches or darts, that's risky, because sometimes it may risk right into the lesion, and then I think it will be a burr trapping. So please be careful that, and then give only a small little tap so that the burr lurches, it does not lurch too much, and that I think is very important. So what are the complications? Bradycardia and AV blocks, slow flow or no reflow, dissection, perforation, side branch occlusion, and hypotension. And what are the rotablation system failure, burr entrapment, burr detachment? Incidentally, I must say that initially when the burr detachment used to take place, it is used to embolize distally. So they started making the wire, the rota wire, if you now know, it is 0.009, but the distal tip, which is a malleable flexible tip, is 0.014. Now therefore the rota burr cannot cross that because its lumen clarity is 0.001210. So it can't embolize anymore. All right, fracture of the wire sometimes takes place. Usually it is benign. It does not create a problem. Let's take one by one. Management of bradycardia and atrial. Why does bradycardia take place? Well, we do not know precisely, because the experiment showed the bradycardia takes place when the burr is rotated in the guide catheter itself. So it's some kind of a Barrow-Jeris reflex or something else is not clear, but bradycardia does take place. And therefore, it is my policy to have pacemaker handy, at least in the IVC or the right atrium, in cases at least of the right coronary artery, or in the proximal left coronary artery, or a dominant circumflex artery, or the left coronary is going to give a collaterals to the totally occluded right coronary artery. In these situations, I think the bradycardia can be really harmful and create a lot of anxiety. Therefore, the pacemaker should be handy. And why not to put in the right ventricle? Well, sometimes people have experienced perforation of the right ventricle, so they are a little skeptic about it. If you take a balloon-tipped right coronary pacing catheter, balloon-tipped pacing catheter, then I think the complications of perforation is very highly minimized. And so limit the ablation time to prevent bradycardia, 15 to 20 seconds. Then come back, give a rest of equal amount of time, like 20 seconds or 1 minute, and then proceed again. Pre-treatment with atropine has been recommended, but I don't believe it. I don't do it. Deactivate the burr when slowing of the heart rate is noted. If the slowing takes place, you take little rest. Ask the patient to cough, and that should be all right. By and large, bradycardia has not produced any harmful effect, and therefore not to worry. And AV blocks. Some operators advance pacemaker, as I mentioned to you, and temporary pacemaker in the special situations. Acha, step burr approach, slow flow and no reflow. Slow flow and no reflow often can be eliminated by appropriate technique. Do not allow to drop in the revolutions by more than 5,000. Do not allow the significant heat to get generated by keep on using the rotablation in an active form at one single site. It will char the lesion. Limit the ablation for 15 to 30 seconds with a rest in between. Slower speed associated with lower platelet aggregation and therefore less likelihood of slow flow or no reflow. Just in case the slow flow, you see that you inject and you say nothing, distal artery is just not visible, no reflow at all, no flow. What could be the possibility? A, intense vasospasm, B, dissection flap, and 3, microvascular sludging. But how do you differentiate these three? The treatment for all these three is very different. Take a microcatheter and go beyond the lesion. If you inject the dye with microcatheter in that part, and if you find there is a stagnation of flow, surely it is a microvascular sludging. On the other hand, you bring the lesion and open it with balloon, the spasm will be broken. But if you find there is only a partial flow and the dissection is seen, I think the treatment is stenting it. 10% is the incidence of dissection, and this is particularly common in angulated lesions or due to wire bias. Therefore, placement of the guide wire appropriately is of paramount importance. Its cutting vector of the device should be appropriately placed. Yeah, set the optimal central vector for burring. Because the increased tension of the rigidity of the wire can cause pseudo lesions and therefore can create dissection of those lesions with intima and media, and this it can be avoided if you have proper knowledge and if you can keep carefully the wire just distal to the lesion by a couple of centimeters. And in between, the angiography should be performed after the wire is placed so that you know that pseudo lesions have developed or not. So, how to minimize the rota guide wire tension, that I already talked with you, that you withdraw the burr, and then I think it will help. Perforation, that I think is a very serious complication. Mechanism is that either you have taken an oversized burr or tangentially oriented burr due to trajectory of the guide wire. More common in severely angulated lesions, and I will show you an example of perforation when I show you videos. This can occur even in elastic vessels, since the strain or penetration of guide wire into the wall will exceed the elasticity of the vessel wall, and ablation of the tissues will take place with potential perforation, especially in angulated vessels. So, how to manage that? First of all, minimize the guide wire bias by proper coaxial guide catheter and guide wire placement. Relaxation of the guide wire is important, and that I think withdrawing it slightly so as to remove the tension on the wire. Undersize the burr in severely angulated vessels, and especially those which are straightened with guide wire or showing pseudo lesions. Wood packing movement, that should be used to avoid excessive cutting. Side branch occlusion, how do you prevent that? Since the secondary protective wire cannot be used, you can't have any other wire whilst you are using rotablation, and that's what careful attention should be given. Whereas this side branch cross, the occlusion in ordinarily bifurcating lesions occurs due to plaque shift or carina shift. Here it will be solely due to microvascular sludging or particles moving into the side branch. I think vasospasm might also take. The burr entrapment, this I think is an important complication. It can occur if burr slips across without burring the lesion adequately. What happens is that when you go inside and you have gone without burring adequately, a lurch or a small latch of the calcium continues to remain in the vessel transversely. And now when you pull back, it travels onto the inner side of the artery. That is where the lesion is, so it will not come out. And I think it is a Kokesi effect or the Japanese doll effect. And there I think you require lots of efforts. So how do you deal? I will deal with little more in detail. The vessel management of entrapped burr. Disengage the guide catheter from the vessel ostium and send the other guide catheter from the contralateral side. Remove this guide catheter. Pass a second guide catheter is intubating the vessel, the culprit vessel, and pass a wire by the side. Usually you require a polymer wire or a strong wire, and usually sometimes even a Conquest Pro wire. And then I think pass a balloon. A small possible balloon might help you after expansion to dislodge the guide catheter, the burr, and then you can pull the burr out. So this is what it was published earlier. And then I think there is one more method which I'm going to show you in my videos. All right. If there is a stuck rotator burr, what can you do? Use a second guide catheter, recross with the second wire, ablate, and then if you are able to pass by the side of the burr, then you cross it with the balloon and then try to dislodge. If not, then you will have to cut off the sheath and then put a guide liner, and I'll show you how you should do that. All right. First case, this was a 65-year-old man with heavily calcified right coronary artery, borderline creatinine. He had multiple PTCAs, proximal LAD, distal LAD, povite to mid LAD lesion, so on and so forth. Now the target vessel that we wanted to treat was right coronary artery. The culprit lesions were at the bifurcation. Syntax score was 30. Heavily calcified artery. You can visibly see the artery, silhouette of the artery and the stents in the LAD. And this is where I passed a wire first. So 7 French guide catheter with the side holes, Filter FC and in PDA and BMW in PLB. 2 wires. 2 mm euphora balloon at 20 atmosphere. Lesion did not yield. So then change the policy. Took a rota wire, 1.25 mm burr. Drive shaft was not able to reach up to the lesion because it can only travel 6 centimeter. The rota burr can travel for only 6 centimeter. Then how do you approach the distal lesion? There are 2 ways. Advance the whole drive shaft as a one piece, like as you advance a balloon on the wire, in 2 ways. Inactivated way or an activated way. Inactivated way is simple pushing the burr into the artery to allow it to go as much as it goes. And then count 6 centimeter from then. Maybe it is within the reach of the burr for the lesion. If not, then you can advance in activated form. The speed of rota in that situation should be about 100,000. You can do it in Dynaglide mode, but it is better to use 100,000 because in Dynaglide it's a servo mechanism. If obstruction is encountered by the burr, it will be overcome by automatic change in the speed by Dyna. But if you are 100,000 and you find that the burr is slowing down or stalling, then there is a concealed lesion there also. So you come to know. Anyway, so we did that, but it still fell short. So we had to, we tried a 6 French guide liner. Heavy calcification, and the guide wire was backing out. And the balloon anchoring was done for this particular guide liner, but it continued to stay at that position only till the balloon was inflated. Moment I deflate the balloon, the whole guide liner would come back. So I stopped the procedure on that particular day and postponed and brought him after 2 days. Started after 3 days with a new strategy. Deep intubation of 6 French guide catheter was planned, and multi-purpose 6 French catheter was prepared for deep sitting by softening it and straightening it. So what do? You take it and pass the wire there. This is a multi-purpose catheter, and then you heat it with the hair dryer. This softens it's made up of polyurethane, so it is softened and it straightens up. This can be done quite easily. Since the hair dryer, Ajay, is not very easily available, you have to bring and asking your permission from your wife, and she would usually not give you because she is not sure that what for you using it. 2 Filter FC wires were advanced for the support to 4 French guide catheter, 6 French guide catheter, the regular one. And for an additional support, even a 0.035 wire. Now with 2 wires inside the guide catheter, 2 wires inside the coronary artery, over this I slided over 6 French multi-purpose catheter, which was already softened by me. And with this, carefully avoiding any loops in the guide in the aorta, gently advance it, and I brought it right up to the lesion, deeply anchoring near the cusp, the crux. And over a microcatheter, the Grand Slam wire was changed to rotafloppy wire, and we started burying. And unfortunately, lesion did not give up even at the speed of 210,000 revolutions per minute, and to my bad luck, the burr got stuck inside the lesion. It did not come out with traction, nor could be advanced further, and it was completely stalled. So now what do? You cut the rota sheath completely. The drive shaft is cut, and the sheath is removed out. So this exposes with the sheath, it exposes the drive shaft now, and over this one can advance the guide liner. Since I did not require any backup because the stalled burr itself was providing me tremendous anchor, so the burr went, the guide liner went easily, but it did not work. And finally the patient had to go for surgery. Passing the wire by the side also did not work, and ultimately the patient had to go for surgery, and he found a lot of difficulty to remove the burr because it was so much embedded. He had to make cut piecemeal removal of the calcium from the endothelium, then did the atherectomy, and he then put a venous patch, and then he performed the plastic. Well, so this is the story about the burr entrapment. Now, one more difficult, because I think the time is over. So this is a heavily calcified coronary artery, and the right the circumflex artery. I had difficulty in not only crossing the vessel, but it would not cross even RC also, CTO, and the I'll proceed straight to the target artery. The wire was advanced, and fine cross microcatheter would not go. In such a situation, what one does is you jam the microcatheter as much as you can, remove the wire boldly, and advance the rota wire. After doing that, proceeded corsair proexis did not cross, and then finally, having placed the rota wire after jamming the corsair with 1.25 rota. That also would not go very easily due to heavy calcification. Ultimately, after several attempts, when the burr became bald, changed the burr, and then finally crossed the OM distal lesion. Bradycardia, hypotension, responded to fluids, and ultimately pacemaker had to be inserted too, and went with the speed. It produced what is known as a neo lesion formation. There it is. You see the proximally. Does this arrow shows here? No, it will not show. You see that proximally there is a slightly ectatic kind of an area here. There I think the burr has traveled to the intima and media. Now there are two lumens. So this is called a new lumen formation, first described by Reisman, and it can be treated easily by stenting. And ultimately after this was up to the left main. So first we placed the stent into the OM, 3 mm stent and 3.5 mm stent, post dilated with pot done in the left main with a 4 mm balloon, and finally this was the final result. I think I'll leave some time for questions and answer because we have a short time. Thank you very much.
Thank you, sir.
Any additional information
Great,
you would
sir.
like to put?
Sir, thank you, sir. I mean, it's an honor to chair a session when your teacher is speaking. So it's a good. So we always learn something from you. 2-3 questions or comments because a lot of fellows are there. You told about atropine which you don't use to prevent bradycardia. I mean, many times nowadays we use aminophylline 250 milligram over 15-20 minutes. So that is one thing. What is your opinion? Secondly, I mean, for rota wire choice, there is floppy wire and support wire. So for osteal lesion like left main ostium or RCA ostium, is it, do you recommend to use support wire or is it okay with floppy wire also?
Okay, so just a word or two about osteal rotablation. First of all, when you deal with the osteal lesion, the guide catheter cannot be selectively intubated into the ostium, but it has to stay a little bit outside the ostium. This you can achieve that when you push the wire, the guide catheter backs out a little bit. You should be thoroughly coaxial. The burring starts from within the guide catheter itself, although that the inside of the guide catheter is PTFE coated and one is worried whether it will embolize or not, but it does not happen that way. You should start from inside. 3, that preferably you should use, especially in the right, the side holes, because so that in case if you wedge it, some perfusion takes place. And then I think whether you use a floppy wire or use a strong wire does not make any difference. And your second question was aminophylline. I don't use it, but I suppose people have described and they can use it.
Sir, it was very informative and comprehensive talk. So, sir, any tips and tricks about rotablation of stents, under expanded stents or say calcified ISR within a stent? So how to, any special tips and tricks for rotablating such cases?
Calcified ISR?
Calcified ISR or severely under expanded stent. if we want to
Severely
expand
angulated.
under expanded stent.
Under expanded stent.
Yes.
Oh, okay. I think so. It does happen once in a while that you have not anticipated, and the stent, I think you find difficult to expand the stent fully. So at that point of time, you stop. Don't do anything at that point. Call the patient after 10-15 days, and then you think you can, now of course you can do it with IVL, but in the past when it was not there, we used to rotablation. And I think from the Spain, there was a paper published in the Management of Instant Restenosis almost 10 years ago with the use of a large size rota, 2 millimeter rotablation, and that they were using it in the treatment. Ultimately, we found out that the instant restenosis, after whatever you can do, it expand it back, and I think the second stent is a much better treatment. Now, so burying that rotablation within the stent itself is not a contraindication. Not at all a contraindication. It is quite possible that it will touch the stent surfaces on the inner side and outer side, and maybe it might even ablate a little bit of part of the stent, etc., but it can be successfully done. Dr. Matthew showed one case in which he did the side branch with rotablation in a stented artery where the side branch was covered with the stent strut. He went through the strut, dilated the strut, and did the rotablation successfully. I would not recommend routinely, but just in case if you are compelled to do, he showed a feasibility. Yeah. A good question. He says now that the orbital atherectomy, when there is a low ejection fraction, since the orbital atherectomy does not produce slow flow, no reflow, because the particle size is 2 microns only. It has a burying capacity on both sides because it does it a loop, and therefore you can ablate while going forward and coming backward. So burr entrapment does not take place. Bradycardia does not take place. So the situations where you are dealing with a low ejection fraction patient, or those where you are likely to think that the bradycardia and hypotension due to microvascular sludging is going to create a problem, I can do that. Moreover, if the artery size is very large and you think that the lesion will not be purchased by the burr, then I think orbital atherectomy is good, because with the speed of 120,000, it revolves around the circle of almost 3 millimeter and more. So those circumstances I would use orbital. It continues to do that, because when you move forward, it ablates forward. When you're coming back, it ablates backward. So it continues to do. When you stop and take your and stall it, then it stops. I think.
Well, I was told that you cross the lesion with orbital, distal to lesion, and then pull back retrograde, and then
For Australias,
not
for-
all the other lesions.
no. For Australias, because that's the only way you can burr while coming back. Yeah.
Yeah.
Okay.
Thanks for excellent talk, sir. With a tortuous vessel, whether we should go with a smaller burr 1.25 or 1.5. Some says that it is 1.5 will not jump, 1.25 will jump too much.
Say that again, please.
Yeah, in tortuous vessel,
Yeah.
whether we should go with a smaller burr 1.25 or 1.5. Some says that 1.25 will jump more in tortuous vessel.
Okay. All right. Now, that's a good question. Vast majority of the burrs which have been entrapped or embedded are 1.25. It's very rare that 1.5 gets embedded. 9 out of 10 times it will be 1.25. So by and large, our standard practice is to start with 1.5 only. You asked for a specific question in tortuosity. There you have to be extra careful. You start with 1.25 only, and then after burying, if it is necessary, then you jump to 1.5. Occasionally it has happened to me that even in tortuous lesions, 1.25 has not crossed, but 1.5 has crossed because of larger amount of energy. So reverse is occasionally true also. So I think it depends on the case situation.
Thank you.
Thank you so
Now,
much, sir.
now,
Sir,
now,
one question,
I
sir.
have developed vocal myasthenia. So no more questions.